from the American Academy of Pediatrics.
April is National Autism Acceptance Month, and the AAP is advocating for early intervention.
A new tip sheet offers guidance for diagnosing autism spectrum disorder within the medical home.
We're really aiming this tip sheet at general pediatricians who want to diagnose autism, not for all of their patients, but for a certain segment of their patients who have very obvious autism symptoms.
Plus, new research shows how moving can affect families' access to resources like WIC, SNAP, and Medicaid.
Moving in general seems to mean that people drop out of the services, but then moving in these really stressful, less voluntary contexts is associated with, really huge increases in odds of falling out.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about how pediatricians can accurately make and document the diagnosis of autism spectrum disorder.
We've been lucky on this podcast to have several developmental and behavioral pediatricians speak with us.
But I know from having worked in community pediatrics how hard it can be to get appointments with specialists in that field. With rising rates of autism diagnosis, limiting autism care to specialists has created a major bottleneck for a lot of families, and primary care pediatricians have to step in and fill this gap.
So how can they help provide a diagnosis for families? What do they need to watch developmentally when a child has autism? How do they organize services in the medical home?
These are excellent questions for our next guest, Dr. Katharine Zuckerman.
Dr. Zuckerman is a primary care pediatrician, professor of pediatrics at Dornbecker Children's Hospital at Oregon Health and Science University, and is on the executive committee of the AAP Council on Children with Disabilities. She's no stranger to the show. She's recorded a Giving Voice on autism disparities in episode 55.
She also recently helped the AAP work on a tip sheet entitled Primary Care Physicians. Are you thinking about diagnosing autism spectrum disorder in the medical home? And she's here to discuss it. Dr. Zuckerman, welcome.
Thank you. I'm a big fan of the podcast.
Oh, well, we're a big fan of you, so we're happy you're here. I imagine many of our listeners are thinking about diagnosing ASD in the medical home. What are the diagnostic criteria for autism?
Great question. I think it's really important that general pediatricians have a good sense of the diagnostic criteria for autism because you really need to be able to apply these in order to give accurate autism diagnoses. Autism diagnoses are based on the DSM-5. There's two primary criteria. The first one is challenges with social communication and interaction. In a young child, that might be things like having challenges making eye contact. Not talking a lot at all is an early sign of autism because children aren't motivated to socially communicate. Really having trouble with back and forth interactions, like playing a back and forth game. Not pointing or other nonverbal communication is also an early sign of autism, especially if a child doesn't point to share interests. Like if there was an airplane in the sky, an autistic kid might not point at it, or if you pointed at it, they might not look at it. So the second major DSM criteria for autism is restricted and repetitive behaviors, interests, or activities. So in a young child, we might see that as sort of the typical things we think of in terms of autism, like flapping your hands or spinning a lot. But it could also be other behaviors like lining up toys is a really common one. Children might also have difficulties with changes in their routine. Like if the mom drove a different way home from school, the kid might get really upset. Or if there was a different care provider at the child's childcare, it might be really challenging for them. It can also extend to sensory issues like being very upset by loud sounds or wanting to smell things or touch them in ways that are unusual. For instance, spinning the wheel of a car instead of playing a pretend game with it. When considering the diagnostic criteria for autism, it's really important that the symptoms started in early childhood. So children need to have the symptoms of autism starting when they're a toddler or shortly thereafter. And the symptoms have to cause impairment to the child and the family. A lot of children have all of these symptoms to some degree. And the difference between autism and typical development is more the degree to which these symptoms cause problems for the child and his or her family.
And, almost every pediatric practice now screens for autism. But how do you go from a positive screen to an official diagnosis?
Screening is a really key step in early autism identification. And you're right, most pediatricians do screen in their primary care practices now. The most common screening tool we use is the MCHAT, or the Modified Checklist for Autism in Toddlers, although some pediatricians are using other tools as well. It's a parent-completed checklist. It can be done in about 5 minutes. For kids who have an intermediate or borderline score on the checklist, it's really important that pediatricians also do the MCHAT follow-up interview, which increases its sensitivity and specificity. So I would definitely encourage pediatricians, if they're using the MCHAT to screen, to also use the follow-up interview. And then traditionally what's happened after screening is that if a child screens positive, they should be referred to a specialist for diagnostic evaluation. We also want them to be referred to early intervention so that they can start therapy while they're waiting for an evaluation. And we also recommend audiology evaluation for all children. This specialty evaluation generally has a very long wait, from 6 months to several years in most places, and that's really problematic. Part of what we're trying to do in this AAP tip sheet that we've developed is to make it so that pediatricians can identify a segment of kids with really obvious autism symptoms who are of preschool age, so under age 5, let's say, and diagnosing those kids in the medical home without having to refer to the specialist and without having to make them wait for a very long time. And our hope here is that we can connect children and families to an autism diagnosis and then the autism-specific services that they need without making them wait so long, because we know that those early years are such a key time for child development, and connecting kids to services early is really in their best interest in the long term.
What are some common conditions that may mimic autism that general pediatricians should rule out before they make a diagnosis?
Understanding the differential diagnosis of autism is really important, because if you're going to diagnose autism, you also need to be able to diagnose all the conditions that aren't autism but are also really important for early intervention. Some of those conditions might be anxiety. For instance, if a child is really anxious all the time, he or she might not be communicating a lot, but it's not because they can't, it's because they're feeling too anxious to do it. So anxiety is a key mimicker of autism. Another such condition is ADHD. Especially as children get older, attention problems can look like a problem with social interactions. Also, kids with ADHD often have repetitive behaviors that might mimic autism. So keeping ADHD on your differential diagnosis is really important. Trauma conditions can also mimic autism. So if a child's experienced abuse or neglect, they might not have had an opportunity to make good social connections with adults, but might do much better in a supportive social environment. And then finally, global developmental delay should be distinguished from autism. Children with autism should have challenges with social communication, but other aspects of their development, like their gross motor development and their fine motor development, should be comparatively less delayed. If a child has global delay, they might be delayed in their social skills, but they might be delayed in other areas just as much or even more. So that's another key distinction you want to make. So all in all, I think it's important for pediatricians, if they're thinking about autism, not to just think about autism, but to think about all the things that might impact a child's development in early childhood, and feel capable to identify those conditions as well and refer them to the necessary resources.
And let's say you've done your due diligence, though. You really believe that this is autism. What's the best way to document that you've made that diagnosis and to ensure that your practice gets reimbursed for the care you're providing?
So in our new tip sheet, which is out on the AAP Autism Provider Resource, what we've come up with is really like a process for pediatricians who are thinking about doing autism diagnosis in primary care to go about doing that in a way that's both accurate and also connects their patients to care and autism-specific services after the diagnosis has been given. AAP is not encouraging pediatricians necessarily to just go diagnose autism anytime they believe it might be the case. Of course, you can do that, but often autism services are really restricted, especially applied behavioral analysis or ABA. If you don't document the evidence behind your diagnosis adequately, So if you just went into a child's medical record and gave them an autism diagnosis, but you didn't show any evidence of your documentation, that might help them get some services, but it probably wouldn't help them get the full range of services that that child's really entitled to. And so we really want to encourage pediatricians who are thinking about autism, first of all, to have the training to do it accurately, and second of all, to document it accurately so that it actually improves access to care. The tip sheet kind of outlines what we think that pediatricians should do, but to sort of make a brief summary of it, we really want to make sure that pediatricians who are diagnosing autism in primary care have adequate autism knowledge. And I'm sure, as you guys know, sometimes our autism training during residency isn't really great or isn't as much as we would probably want to know. And so just learning more about autism in the first place by reviewing the DSM criteria. Also, AAP has a great free PediaLink course that reviews much of the content of our 2020 clinical report on autism, which also is a great resource. I think it's also important that pediatricians learn about their state and local programs like early intervention and early childhood special education. They need to know what therapy agencies are there to provide developmental services, and also about family support programs like Autism Society, which is in every state, or family-to-family health information centers. And they also need to know what the situation is with insurers and payers in their state. For instance, are there private insurers or Medicaid allowing diagnosis by general pediatricians? Because certain payers often require a certain provider type to make the diagnosis. And so even if you did an awesome diagnosis, in certain states, you must be a specialist to make the diagnosis. And then what documentation is really required? In most states, to get applied behavioral analysis therapy, which is an evidence-based therapy for autism, but is one of the more expensive therapies out there, you're going to have to document a structured behavioral measure. The one that everyone learned about in residency is called the ADOS, but there's a lot of newer, shorter measures out there that are more appropriate for a primary care setting. So a pediatrician might want to invest some time in learning how to do one of those measures. And then I think also understanding the billing environment, which you might have to talk with your clinic or your institution about how you're going to bill for this. You can always bill for your time, but in some places you can bill testing codes as well, which can enhance your payment. And as we know, for pediatricians out in the community, autism evaluations can take time. And so if you're not being adequately compensated for that time, it might not be a practice that you really want to sustain.
Katie, you alluded to this earlier, but in terms of developmental monitoring for our patients with autism, how should we go about that as general pediatricians?
So developmental monitoring is distinct from developmental screening. Developmental screening is what we do at standard visits during our well-child checks. So for autism in particular, we do structured screening at 18 and 24 months if we're following the AAP guidelines. Developmental monitoring is what we do at every single visit, where we're observing the child, eliciting parent concerns, getting a developmental history, and watching the child longitudinally. And this is one of the really great things about primary care, right, is that we know these children. We've seen them often since they were newborns, and we know their whole families. And so often we have these great relationships with families that we can use so that if a child does begin to show some signs of autism, we have a trusting relationship with that family. We also are their medical home and can help connect them with services. And so that's really great.
And I'm glad you mentioned services, because at this point, if you've already made a diagnosis of autism in your office, what are the most important supports or referrals that you want to make sure your patient has in place?
So, really the fundamental for all children, even before you make a diagnosis, is their state early intervention or early childhood special education program for kids under 5, say. We should be referring to those programs before we make an autism diagnosis assessment. And in fact, we should do that as soon as we're concerned about a child's development. And so hopefully by the time you're seeing a child for autism concerns, you've already made that referral, but we know in practice, not everybody goes. And so it's important to make that referral and explain the program to families so they understand what it is and that there's no cost sharing for families, so it should be free to them. And really encourage them to go, because that really helps connect the medical system with the school system for kids with developmental concerns. I think other than that, after an autism diagnosis, or even before, kids can really benefit from speech therapy, occupational therapy. We also know that many children with autism have motor delays, and so a lot of them can also benefit from physical therapy. In terms of autism-specific therapies, like I said before, a lot of them are really contingent on having appropriate diagnostic documentation. So if your patient has that documentation, you can refer them for applied behavioral analysis. That is a pretty intensive therapy that often is, I would say minimum 10 hours a week and sometimes up to 40 hours a week if the family wants to do that. Also, in many areas, there's great autism parent training programs where a lot of the therapy can be delivered by the parents. And so there's a lot of different choices for families. I don't think that one choice is perfect for every kid. And, obviously families are the experts in their children and they know what therapies are probably going to be the best for them. But I think it's our responsibility as pediatricians to let them know what's available and also to let them know what benefits they are entitled to as a parent of a child with a disability. So, for instance, often having an autism diagnosis can qualify children for developmental disability services in their state or could qualify them for their state Medicaid program or could qualify the family for supplemental Social Security. And so that's really important to be knowledgeable about as a pediatrician as well.
So, Dr. Zuckerman, I'm primarily a hospitalist, but part of my practice is in outpatient community pediatrics, and I'm wondering, who's the audience for this tip sheet?
So we're really aiming this tip sheet at general pediatricians who want to diagnose autism, not for all of their patients, but for a certain segment of their patients who have very obvious autism symptoms. And sometimes in the research world, we call this frank autism. These are the 2-year-olds who come into your office and they're flapping their hands and they're not making eye contact and they probably have minimal speech. We know that from the research, a lot of those children do not need to see a specialist for diagnosis. And furthermore, there have been several recent studies showing that general pediatricians who are trained in autism diagnosis can diagnose that population of kids with as much accuracy as a specialist. And so this tip sheet is really aimed at people who just want to take sort of the least complicated kids and try to take them on in their own pediatric practice. And I think one of the messages I want to say to general pediatricians is that you can definitely do this, but it's going to take an investment of time and effort and a little bit of learning on your part. But on the other hand, it has huge benefits that those kids can be seen in your clinic. You can get the diagnosis done. You can really reduce the wait. It probably helps with equity because there's not so many payment issues in the primary care setting as there are in specialty settings. And also, those families, they're going to trust you and your community resources really well and probably are one of the best people to connect them with the subsequent therapy resources that they need.
The tip sheet you helped write is so comprehensive. I feel like we're just scratching the surface of this thing. But if you had one last takeaway for our listeners about diagnosing and supporting children with autism spectrum disorder in a general pediatrician's office, what would it be?
I think anybody can diagnose autism. That's as easy as putting the diagnostic code in a child's medical record. But it's really important that pediatricians not just give the diagnosis, but that they give the diagnosis with accuracy and with documentation that's needed to really help the child get the right services that they need so that the child's development really can be optimized.
Well, we're hoping everybody goes and uses that toolkit for their offices. And thank you so much, Dr. Katie Zuckerman, for joining us today.
It was fun. Thank you for inviting me.
To read Primary Care Physicians, are you thinking about diagnosing autism spectrum disorder in the medical home? Visit our website at aap.org/podcast.
Coming up, we'll look at how moving can affect families' access to social services.
David, sometimes I stop and think about how lucky I am to have a house that I love. It's so nice to be able to come home from work and enjoy a safe space with my family.
Joanna, I also feel so fortunate to live where I do and to have a place my kids can come back to when they aren't at work or at school.
Having secure housing isn't something that everybody can count on, and not having it is a real stress, a stress that can affect your health.
That's an interesting observation, Joanna, but how do you quantify the relationship between housing and health? It's not an easy thing to study, which is why a new paper in Pediatrics entitled Moving Due to Unaffordable Housing and Disrupted Social Safety Net Access Among Children is so thought-provoking.
Here to discuss is the lead author, Dr. Kathryn or Kate Leifheit. She's an assistant professor of pediatrics at the David Geffen School of Medicine at UCLA and a social epidemiologist and public health services researcher. Kate, welcome to the show.
Thank you. Hi, Joanna. Hi, David.
Hi. So, we've all been hearing about this housing crisis in the United States with high mortgage rates and increasing costs of housing. How does this crisis affect families, particularly families of lower socioeconomic status?
Yeah, I think another question is, how doesn't it affect families? When you're spending, over half of your income on rent, which is true for the majority of low-income families in the U.S., that means that any unanticipated expense can push you to the point where you're not able to pay your rent and put you at risk of an eviction, which we know are incredibly disruptive, stressful life events in a family.
And for this study, you used something called Children's Health Watch to get data. Can you tell us about what that is?
Right. So Children's Health Watch is a national kind of child health surveillance study. They have, I think, 5 sites across the U.S. We use data specifically from Baltimore and Philadelphia, and it's been an ongoing study for, I think, almost 20 years. Our study uses data from 2011 to 2019. And it's survey-based data of families who are either waiting for a primary care pediatrician appointment or an emergency doc appointment with their kids. They complete a short survey that asks how they're doing, and importantly for our study, asks about their housing status and also their social safety net use.
And what sort of housing status served as inclusion criteria for your study so we know what kinds of families we're talking about?
Right. So we compare 3 different groups in our study. There are people that didn't move at all in the past year, and there are people that moved for what we call non-cost driven reasons. Those tend to be sort of positive moves. You're moving to have more space for your family or to be closer to a school. These are choices that families are making. And then there are the cost-driven moves, which are basically moves because you can't afford your mortgage or your rent, you're being evicted, you're being foreclosed upon. So we think of these as less voluntary and more stressful.
And you also looked at social services, including WIC, SNAP, and Medicare, in relation to housing insecurity. And what did you find there?
Right. So we look at people who we think are eligible for those 3 social safety nets, WIC, SNAP, and Medicaid. And then we look if there have been any disruptions to their access. So people who we think should be eligible but are not currently receiving those services. And this is a little bit in the weeds, but we also exclude people who dropped out of those services because they're no longer income eligible. So again, we're looking at kind of dropping out of those services for reasons we think are not voluntary. So not because you're no longer income eligible, which would be sort of a quote unquote good reason to no longer be enrolled. So we look at this association between the 3 different kinds of moves and then dropping out of any of these services. And we find that experiencing one of those sort of more positive, non-cost driven moves is associated with a 14% increase in odds of any program disruption, but then experiencing one of these cost-driven moves is associated with a 44% increase in those odds. So there's kind of this dose-response relationship where moving in general seems to mean that people drop out of the services, but then moving in these really stressful, less voluntary contexts is associated with, really huge increases in odds of falling out.
Were there aspects of these results that surprised you, or was it sort of what you expected to find?
One thing that stood out to me is that there was a relatively high frequency of falling out of social safety nets in general. So even in the group that didn't move, about 1 in 5 had some evidence of disrupted access. Which to me just really highlights how difficult it is to stay enrolled in SNAP, WIC, and Medicaid. We place a tremendous administrative burden on families. The amount of paperwork you have to do, everything you have to do to recertify and verify that you're still eligible for the programs means that it's unfortunately fairly common for families to fall out of these really necessary services.
So, Kate, you mentioned things like how cumbersome paperwork can be for families. Do you have any recommendations for what pediatricians can do to make these things easier for their families to stay engaged with?
Sure. So I think it's always good to check whether families are enrolled in these programs. And if they're eligible but not enrolled, connect them with a clinic-based social worker to help them access the services. And I think in particular, screening for housing insecurity. And if families are about to experience one of these moves, either do what you can to prevent it, refer them to housing supports, and or make sure that they know how to stay connected to SNAP, WIC, and Medicaid during this really trying time.
Such good advice, Kate. Before we let you go, do you have any last takeaways about unstable housing and social services?
Yeah, so I tend to think of myself as a housing researcher. So we sort of came into this paper thinking about, how does unstable housing affect your access to these vital safety nets? But actually, the way that our study is designed, it's equally plausible that we could be measuring the reverse effect. So basically, how does losing access to SNAP, WIC, or Medicaid affect your housing situation? And that's particularly relevant right now because a bunch of children across the country are getting dropped from Medicaid in particular. We're in this context of sort of the Medicaid unwinding, where 3 million kids across the country are losing access to Medicaid because the end of sort of pandemic policies. So it does make me wonder and worry that we might see a big spike in housing insecurity related to the rollbacks of some of those pandemic policies.
Dr. Kate Leifheit, thank you so much for joining us today.
Thank you.
To read the paper, Moving Due to Unaffordable Housing and Disrupted Social Safety Net Access Among Children, visit our website at aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Mine is so simple, but every spring, one of the farms around Goldsboro puts up a farm stand right across the street from the hospital and sells these pallets of fresh strawberries. You can't even buy fewer than that. So not only am I drowning in the most amazing farm fresh just picked strawberries, but I have to buy enough to share with everybody on the floor. So I'm like strawberry guy right now at Goldsboro, and I'm loving it.
I can almost taste how sweet they are, But what's even sweeter is my Say Ah, which is that I got promoted, David.
Wow.
So I'm coming back from maternity leave, and I found out I'm an associate professor now, and I'm almost going to cry on the podcast.
Wow.
It's so hard to come back to work after you've been off for your baby, and then to get promoted, it's just a nice value added, they want me.
Oh, wow. Well, they should. They should. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about supporting the family after the death of a child.
We'll speak with the co-author of a new clinical report, Dr. Arwa Nasir. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.